Hello, my name is Chris Jacob. I am a PGY5 Cardiology Fellow at Ascension Macomb Oakland Hospital. I am presenting Kounis syndrome, a STEMI triggered by anaphylaxis. The authors have no relevant financial relationships. Kounis syndrome is described as acute coronary syndrome that is triggered by an allergic hypersensitivity event. A 69-year-old male with past medical history of coronary artery disease with a prior left anterior descending artery stent and anaphylaxis to amoxicillin presented to urgent care with subacute upper respiratory infection symptoms. He was inadvertently prescribed amoxicillin clavulanic acid without his allergy being identified. After the first dose, he promptly developed acute dyspnea, urticaria, and throat swelling. EMS was activated and began treatment for anaphylaxis. He then developed acute severe anterior chest pain. EKG, as shown on the right, showed ST elevation in the inferior and lateral leads with reciprocal depression in the anterior leads. The cardiac catheterization lab was emergently activated for STEMI. However, the catheterization showed no significant coronary artery disease. The patient's ST elevations resolved while in the cardiac catheterization lab, and his other symptoms resolved fully with time. The patient was advised to strictly avoid all penicillins in the future. Kounis syndrome was first described in 1991 as allergic angina syndrome. It is characterized by acute coronary syndrome that is triggered by an allergic source. These triggers can include drugs, foods, insect stings, or any other source of allergy. There are 3 variants described. Type 1 is coronary vasospasm, and this is typically seen in patients with no significant coronary artery disease. Type 2 is acute myocardial infarction related to plaque erosion or rupture. Type 3 is late or very late stent thrombosis, and this is seen in patients with prior remote stent implantation. The pathophysiology of all 3 types is related to mast cell activation and the related pro-inflammatory cascade. Treatment consists of concurrent management of both the acute allergic reaction and the acute coronary syndrome. Standard protocols for each are appropriate. However, specifically, beta blockers should be avoided due to the increase in coronary vasospasm that can occur due to unopposed alpha adrenergic activation. In conclusion, Kounis syndrome is an important diagnosis to consider in the setting of acute coronary syndrome. Identification of a concomitant allergic event can help dictate optimal management strategy. Also remember to avoid beta blockade in these cases due to the risk of increased coronary vasospasm from unopposed alpha adrenergic stimulation. Thank you.